Hello, everyone. Welcome to my YouTube presentation. My name is Garrett Bauer. Topic today is going to be sepsis. What is sepsis? Why it happens? The signs and symptoms, what to watch out for, and how to prevent it. I think it's a really big key of this presentation. Let me just tell you about myself a little bit. I come from a medical background. I work as a volunteer fireman for a few years. I worked on an ambulance through Riggs Ambulance Service as an EMT for the last 3 years, and I'm currently working as an emergency room technician at Mercy Medical Center here in Merced. This disease kind of hits home because I do see it a lot, and other than sepsis, we get a wide spectrum of patients coming in for different things, and this one here I do believe is preventable based on how we, as a patient and as a sole provider for our own care, are so in control of our decisions, and it really does affect the rest of our lives and the people around us, and as well as a healthcare perspective. So as doctors and nurses and techs, performing at the best of our abilities and not getting complacent is a really key point. So again, sepsis is a big pool of classifications of infections that ultimately round itself back to this one infectious state. So let's look into it. So what is sepsis, you might ask? According to the Center of Disease Control and Prevention, sepsis is defined as the body's extreme response to an infection. Now, this infection, again, is classified with a bunch of different other infections. They're all connected, right? So an infection that you might not already have as a patient in the ER, whether it be a skin infection, infection in your lungs, urinary tract infection, our bodies trigger this chain reaction throughout in attempt to heal itself. Okay, let's get into the septic mindset. The Latin definition of sepsis is to be rotten inside. So an infection has started inside of our bodies and is working its way throughout. So there are multiple stages of sepsis, starting with SIRS, which is systemic inflammatory response syndrome, and on the other end of the spectrum we have MODS, which is multiple organ dysfunction syndrome. So it's kind of a systemic attempt to rid our bodies of the infection, and then kind of our last ditch effort in MODS. So again, just repeating myself, it is inevitable. I do believe the universal inevitability regarding patient negligence as a healthcare professional and self-negligence. So, and it might even be a mindset too. It's I see a lot of older patients that want to hang on in terms of living at home and wanting to be self-sufficient when really they cannot take care of themselves. And so having the ability to swallow your pride sometimes is the best option, and to be prideful, you are in some situations, patients are neglecting their health for their pride, which is interesting to think about. And again, it's very preventable, very, very preventable. Again, there's certain situations like lung infections that are, more airborne or droplets, and that they're floating around in the air. And so it's not really a result of what you have been doing or what you're doing. It just happens. Okay. And it's kind of those that we have to take into consideration. So here we have SIRS, right? So systemic inflammatory response syndrome. Kind of the generic definition of that is, according to Dr. J.A. and his HealthJade research team, SIRS is an exaggerated defense response of the body to a specific stressor, whether it be an infection that we've covered, a traumatic injury, car accident, GSW, surgery, or just acute inflammation in attempt, right? So that you have this defense response in attempt to localize and eliminate that infectious source. So whether it be from the inside of the body or the outside of the body. So signs and symptoms of SIRS. Again, let me just cover one more time. So SIRS is just kind of a generic inflammatory response, right? You can have like compartment syndrome from internal bleeding that you have an inflammatory response, and technically it would be considered SIRS. It just depends on what's going on. So let's just cover the symptoms. We have a temp of 38.0 or greater, indicative of a fever. Anything less than 36 degrees Celsius is hypothermia. We have a heart rate, and let me clarify, a resting heart rate of 90 beats per minute. Again, if you're moving around, it's way different. You're exercising, obviously. If you're doing cardio, you're going to reach maybe, twice that. But you're laying in bed, you're relaxing, your heart rate should not be 90. We have a respiratory rate greater than 20. Not good. Then we have this PaCO2 less than 32 millimeters of mercury. So again, PaCO2 is kind of an arterial access. So usually when we draw labs, it's usually from a vein. We're going to PaCO2, we're going to draw blood from an artery and determine a level from there. We have a white blood cell count of 12,000 or more, which is indicative of that our bodies are fighting off an infection, and we're really working hard to kind of expel that infection. And then on the opposite end of the spectrum, which is way worse, you're having a white blood cell count of less than 4,000, which is not good, because it's pretty much stating that we're losing the battle and that we don't have nearly enough white blood cells to win the war. And so basically it's actually recruiting immature white blood cells to supplement the adult white blood cells that are already fighting. And so not good. So the next stage we have is kind of sepsis and septic shock. So SIRS in the slide before isn't really classified as sepsis unless you have two or more of those symptoms present and a known infection source. So you can have a fever. A lot of people get a fever. Then you can have a heart rate of 90 or 95 or 100. But if you don't have a known infection source, it's not technically classified as sepsis. So we also have septic shock, which is two SIRS symptoms present, two or more. We have a known infection source. And then the only difference is what I put here is an aggressive hypotensive state of our body despite fluid challenge. And I also put the fluid challenge kind of protocol, which is 30 milliliters per kilogram. And there's a little example I put as well. So if you have a 50 kilogram patient, usually that's around, I believe that's 120 pounds, 130 pounds, pretty small individual. their course of treatment, they'll get 1,500 milliliters of normal saline or fluid in attempt to increase that blood pressure. And if it does not correct itself with the fluid, we can classify them as in septic shock. Okay, so this is so MODS. So we have multiple organ dysfunction syndrome. This is one of the worst cases that you can kind of get into in sepsis. So again, it's the two or more SIRS symptoms, and that's just kind of the bare minimum. When a patient's in this state, they're more than likely expressing 4 to 5 symptoms. They're maxed out. They're not doing well. Again, a known infection source, hypotension, despite fluid challenge, and then you have organ dysfunction or organ failure. So decrease in respiratory drive. They might be on a BiPAP. You have you could have kidney failure or decreased kidney function. Little urinary output might be a symptom of that. Cardiac, could have decreased cardiac function. Usually patients in this state have an electrolyte balance. Potassium plays a huge role in muscle contraction, and so arrhythmias can derive from electrolyte imbalances. I believe, as Professor Evan did cover. And also wanted to add that septic shock, which is in the slide before, and MODS, the survival rate is 50% usually once you get in it. Again, these are all usually very preventable, and negligence is the price to pay. I really truly believe. So let's look at the next slide. Just cover kind of routes of contracting sepsis. I got UTIs, usually bacterial. E. coli and Staphylococcus account for a majority of the bacterial infections when it comes to the urinary tract. It's most commonly occurred in women due to open reproductive systems and the length of the urethra. So usually males that might have a slight infection or bacteria that's backed up maybe a quarter or half into the urethra. Once we urinate, we're able to push out a lot of that bacteria because we just have the time to. The urethra in a female is so short that by the time it takes for them to pee again, that bacteria might spread already up into their bladder. So it's just kind of the faulty mechanism of the anatomy. So also bedbound patients have an exponential increase in infection contractility due to their ability to clean themselves. And that's where I went into kind of the healthcare aspect, and knowing that a lot of these people that come from either skilled nursing facilities, they cannot care for themselves. And so UTIs are very easily contracted due to patients sitting in their own urine and their own feces for hours, and it's sad, but that's the world we live in. So I also put Foley catheters are also a really good tool to use. Again, as a physician, I can see I've had a few conversations with a couple of ER physicians that the risk versus reward of placing catheters in patients. If you do, if the decision is made, then the likelihood of an infection is increased, even though it makes the job a little bit easier. Also, one thing to add, so PureWicks, I'm not sure how prevalent they are in nursing facilities, but in the ER, they don't, they sit pretty much on the labia in between the vaginal lips. And so a suction's hooked up to this device, and it allows for urine to be sucked through into a canister. So I really like this device because it's not so invasive, but it also gets the job done. So we'll move on. Ulcers. This is a really huge topic and problem with patients that are bedbound. There's multiple stages. You have stages 1 through 4, and then you have kind of a long-term full thickness tissue loss that usually needs surgery to be removed, and then you have kind of a unknown depth tissue injury that also needs surgery to be removed into the cyst. So sometimes those infections can spread to the bone, and gangrene can result from these infections and the loss of limbs. And so they said ulcers can lead to sepsis if untreated. Of course, the severity determines the plan of action and the attention needed. Usually you have a stage 4 or a stage 3 that has been left alone for a while. It needs a lot of wound care, and there's a lot of wound care specialists that are even here in the valley that's all they deal with is just cleaning people's wounds so they can heal, which is really takes a real special soul to do, I believe. So I don't think really viral has a whole lot to do with wounds, but I think a majority is bacterial and fungal infections. Tissue involvement provides direct access into the bloodstream. Of course, ulcers could form also by diabetes patients that are hypoglycemic, and pretty much the body's just eating itself away. So, all right, that's it. That's all I have for now. Here's are my references. Hopefully you guys enjoy. Thank you.